Imagine handing a newborn baby, like a perfectly measured bottle of plain water, on a sweltering 100-degree day.
I mean, it sounds like basic common sense to keep them hydrated, right?
Exactly. But biologically speaking, doing that actually puts that infant in grave neurological danger.
It really does.
Welcome to the deep dive. You know, whether you are a neonatal nurse prepping for a clinical shift or a parent meticulously tracking feeding charts, or just someone endlessly fascinated by the engineering of human biology, you have definitely seen that infant nutrition is a topic completely drowning in opinion.
Oh, absolutely drowning.
Yeah. But today we are stripping away the heavy guilt tripping. We are ignoring the bumper sticker slogans like breast is best and strictly decoding the fascinating biology, the physical mechanics, and the rigorous science of how human beings fuel their absolute newest members.
And to do this, we're pulling from a highly detailed clinical source.
Right. It's a chapter titled Comprehensive Guide to Newborn Nutrition and Breastfeeding Management by Valerie Coleman and Gary Galati. Okay, let's unpack this.
If we connect this to the bigger picture, infant feeding is not just a simple transfer of calories to sustain life.
Right.
We are looking at an incredibly intricate evolutionary system. It involves complex social interaction, deep psychological bonding, and a dynamic immunological dialogue between two bodies.
Now,
Yeah, this fluid literally programs the foundation for a human being's physiological future.
so going back to that water example, I know people say not to give babies water, but seeing the clinical reasoning behind it in this text really drives home how fragile that foundation is.
It's incredibly delicate.
Like the biological parameters for a newborn are just intensely tight.
They are razor thin. A newborn's fluid balance and caloric intake have essentially zero room for fluctuation.
Zero room.
Right. A standard formula, or human milk, is precisely calibrated to deliver roughly 19 to 20 kilocalories per ounce. And breast milk is already, 87% water, which entirely meets their hydration needs.
So adding more is just redundant.
Worse than redundant. If you introduce plain water, you fill a stomach that is roughly the size of a cherry at birth.
A cherry. Wow.
Yeah, so the infant misses out on the dense calories they urgently need to grow. And more dangerously, you risk hyponatremia.
Because their kidneys just aren't mature enough to filter out the plain water without flushing out essential electrolytes along with it.
Spot on. The immature kidneys cannot efficiently handle a free water load.
Okay.
When plain water enters their system, it rapidly dilutes the sodium levels in their bloodstream.
Oh, that makes sense.
And when blood sodium drops precipitously, fluid naturally shifts into the body's cells to try and equalize the pressure. In the brain, this causes the cells to swell.
Which is terrifying.
It is.
Yeah.
That swelling leads to severe neurological complications, including lethargy and life-threatening seizures.
Which makes total sense when you break down the mechanics.
Yeah.
The liquid they are meant to drink is essentially a highly specialized macronutrient protocol. Wait, so babies are basically on a high-fat, liquid-only diet, like they're doing a specialized keto, but with lactose.
That's actually a pretty great way to think about it.
The protein structure is what really caught my attention, though. Human milk has a weight-to-casein ratio of about 60-40,
Right.
whereas unmodified cow's milk is 20-80. Why does that specific ratio matter so much for an infant's gut?
Well, it dictates the physical mechanics of how the stomach empties. Whey protein remains largely liquid in the acidic environment of the stomach,
Okay.
which means it passes through the system quickly and is easily digested by an immature gastrointestinal tract.
And casein.
Casein, however, forms these tough, rubbery curds when it interacts with stomach acid. The 20-80 ratio in cow's milk creates large, difficult-to-digest curds that sit really heavily in the gut.
Ouch. That doesn't sound comfortable.
It's not. The 60-40 ratio in human milk creates very soft, flocculent curds. This specific protein engineering is why breastfed infants experience rapid gastric emptying and produce very soft stools.
And the carbohydrates are just as mechanically specific. The text highlights these compounds called oligosaccharides.
Yes, those are fascinating.
But the text says the baby doesn't even digest them. If the baby cannot absorb these carbohydrates for cellular energy, why is the mother's body expending the calories to manufacture them?
Because they function entirely as prebiotics.
Really?
Yeah, the mother is not actually feeding the infant with these oligosaccharides. She is feeding the infant's microbiome.
Mind blown.
Right. When a baby is born, their gut is essentially a sterile blank slate. The oligosaccharides pass undigested through the stomach and into the lower intestine.
Bacteria are.
Exactly. They serve as a highly specialized food source for beneficial bifidobacteria.
Okay.
By nourishing these specific bacteria, they promote an acidic environment in the gut. That acidity actively suppresses the growth of dangerous gram-negative pathogens that could cause systemic infection.
Wait, but if the evolutionary blueprint of breast milk is so perfect, why do all newborns need a vitamin K shot at birth, regardless of how they are fed?
That's a great question.
Like, if the biological system is so flawless, shouldn't that essential vitamin just be in the milk?
It comes down to timing and that exact blank slate gut environment we just talked about.
Okay, walk me through that.
In human beings, vitamin K, which is a crucial catalyst for the blood coagulation cascade that prevents severe bleeding, is synthesized by our gut bacteria.
Oh, I see where this is going.
Right. Because the newborn gut is sterile at birth, they lack the bacterial flora to produce it. It takes several days for the oligosaccharides to cultivate that bacterial garden.
So the shot is basically a bridge.
Precisely. The intramuscular vitamin K shot bridges that highly vulnerable gap. It prevents hemorrhagic disease of the newborn, which can cause catastrophic bleeding in the brain, while the microbiome gets up and running.
So the milk has to physically construct the gut environment before the baby can even function independently.
Yes.
Which means this fluid isn't just a static recipe of macronutrients, it's an active living tissue.
Living tissue, exactly.
The text notes it contains macrophages, T and B lymphocytes, and epidermal growth factors. Here's where it gets really interesting. It physically morphs across 3 distinct stages to match the baby's developmental timeline.
We call their stages lactogenesis.
Right.
Lactogenesis produces colostrum. This is the thick, yellowish fluid present in the first few days postpartum.
The liquid gold, as they say.
Exactly. It is relatively low in volume, but densely packed with secretory IgA antibodies, providing immediate immune defense. And it also serves a very specific mechanical function in the digestive tract.
Which is?
Colostrum acts as a natural laxative.
Oh, right, to clear out the meconium.
Exactly. Meconium is the dark, tarry first stool made of amniotic fluid and cellular debris ingested in utero.
Sounds delightful.
It's incredibly rich in bilirubin. If the meconium sits in the infant's gut for too long, the bilirubin gets reabsorbed back into the bloodstream,
Which causes jaundice.
drastically increasing the risk of severe newborn jaundice, yes. The laxative effect of colostrum flushes it out of the system quickly.
Then the body transitions to stage 2, the transitional milk, and by day 10, stage 3, the mature milk. But the text explains that the milk also changes during a single feeding.
It does.
It starts out as watery foremilk and transitions to high-fat hind milk.
Mm.
What is mechanically happening inside the breast to cause that shift? Like, are there 2 different storage tanks being tapped?
No, it is a single continuous process driven entirely by fluid dynamics.
Fluid dynamics,
Yeah.
really?
Inside the breast, milk is produced and stored in small sac-like structures called alveoli. As the breast sits full between feedings, the heavy, sticky fat globules naturally adhere to the walls of these alveoli.
While the watery part moves forward.
Exactly. The more watery milk pushes forward down the ducts toward the nipple. When the baby begins to feed, they first receive this watery foremilk, which satisfies their immediate hydration needs.
So switching the baby to the other breast too quickly is like letting them drink the soup and taking away the plate right before the heavy steak arrives.
That is a perfect analogy. As the breast empties, the mechanical action of the milk flowing and the baby pulling creates a suction.
Okay.
This suction literally washes those sticky fat globules off the walls of the alveoli, pushing them down the ducts. This high-fat hind milk delivers the dense calories necessary for optimal neurological growth.
And keeps them full.
Right, keeps the baby satiated between feeds. A premature swap deprives them of that dense caloric load.
Man, that's incredible. But what happens if the timeline goes completely off script? Say the baby arrives at 30 weeks. Preterm babies missed out on crucial months of growth. Does the milk recognize that deficit?
What's fascinating here is that the mammary gland's cellular response is highly attuned to gestational age.
Wait, really?
Yes. When a mother delivers prematurely, the sudden shift in placental hormones triggers the milk-producing cells, but the tight junctions between these cells remain somewhat permeable.
Permeable meaning things can slip through.
Exactly. This physiological state allows higher concentrations of plasma proteins, sodium, and iron to pass directly into the milk.
Wow.
The result is a specialized fluid uniquely tailored to catch that premature infant up on the rapid skeletal and neurological growth they missed in utero.
It's literally the ultimate smart fluid.
Yeah.
But a perfect biological product is totally useless if the delivery system fails.
Right, the mechanics matter.
The baby is relying on a biological pump, and the text breaks down a strict supply and demand system governed by two hormones, prolactin and oxytocin. How do these two actually divide the labor of feeding a baby?
They handle completely different phases of the operation. Prolactin is the synthesis hormone.
Okay.
Its primary job is to stimulate the glandular tissue to manufacture the milk. Every time the infant suckles and effectively empties the breast, prolactin levels spike in the bloodstream.
Like putting in an order.
Essentially putting in an order for the next batch, yes. The more the breast is empty, the more prolactin is released, and the higher the subsequent supply will be.
So prolactin is the factory manager taking the supply orders, and oxytocin is the shipping department getting it out the door.
That's exactly right. Oxytocin governs the milk ejection reflex, commonly known as the letdown.
Okay.
When the baby suckles, or sometimes just when the mother hears a baby cry or even thinks about her infant, the hypothalamus releases a surge of oxytocin.
And it does what physically?
It binds to receptors on the myoepithelial cells, which are tiny, muscle-like bands that wrap around the milk-producing alveoli. Oxytocin causes these bands to physically contract.
Squeezing the milk out.
Exactly,
Yeah.
squeezing the milk out of the alveoli and forcefully propelling it down the ducts toward the nipple.
But oxytocin is a systemic hormone. The text notes it also causes the uterus to contract. So the shipping department is also doing structural repairs on the warehouse, causing those painful postpartum afterpains.
It is. The simultaneous contraction of the uterus serves a critical survival function.
How so?
It helps shear off the blood vessels at the site where the placenta detached, essentially clamping them shut to prevent massive postpartum hemorrhage.
Oh, wow.
It causes cramping and discomfort, but it is a vital physiological mechanism for maternal healing.
The whole system crashes, however, if the physical connection between the baby and the mother is off. The source places a massive emphasis on the mechanics of the asymmetric latch.
Yes, the latch is everything.
The infant's chin has to hit the breast first, their mouth has to cover more of the lower areola, and their nose has to be tilted away so they can breathe. Why is a perfectly centered, symmetric latch a bad thing here?
It comes down to the internal anatomy of the infant's mouth. If a baby latches symmetrically, meaning their mouth is centered directly over the nipple like a bullseye, the nipple sits right behind the baby's gums, pressed against the hard palate.
That sounds painful.
It is. When the baby begins to suck, their tongue will rhythmically pinch that highly sensitive tissue against the bone. This friction causes intense pain, blisters, and severe tissue damage.
Which quickly leads to cracked, bleeding tissue and a lot of distress.
And very often, the early cessation of breastfeeding entirely. In an asymmetric latch, the baby takes in a large mouthful of the breast tissue entirely below the nipple. This specific angle draws the nipple far back into the mouth.
Away from the gums.
Exactly, resting safely against the soft palate where there is no friction. The baby's jaws then compress the milk sinuses located beneath the areola, efficiently transferring the milk without damaging the surface tissue.
And timing is everything for getting that physical alignment right. The text points out that crying is actually a late sign of hunger.
Very late, yes.
Trying to get a screaming, flailing infant to execute a complex, asymmetric mechanical latch sounds impossible.
Yeah.
You have to catch the early cues, like rooting or bringing hands to the mouth, before their nervous system escalates.
A disorganized crying baby cannot coordinate the tongue, jaw, and breathing required for an effective latch.
Makes sense.
Their tongue often pulls back or points up. The caregiver has to soothe the infant's nervous system first, bringing them back to a calm, alert state before they can mechanically attach and extract milk efficiently.
Biology doesn't happen in a vacuum, though. It happens in the messy, diverse real world. We are talking about varying family structures, distinct cultural traditions, and literal physical roadblocks.
Absolutely.
This clinical guide makes a point to emphasize that infant feeding is deeply embedded in culture. They highlight the Hispanic practice of las dos cosas, combining breast milk and formula to ensure the baby is robustly fed,
Yes.
and the Korean tradition of consuming seaweed soup to boost maternal milk supply.
It reflects a necessary shift in clinical care toward cultural humility. Healthcare providers cannot ignore the context of the family.
Right.
If a provider understands las dos cosas, they can better support a family's feeding goals without framing formula supplementation as a failure, but rather as a recognized cultural practice of ensuring abundance and health for the infant.
And the text brings that same individualized approach to the LGBTQIA+ community. It details chest feeding protocols for trans men and outlines how non-gestational co-parents can use induced lactation protocols and supplemental nursing devices.
It's an important inclusion.
It's fascinating how the capacity to nourish an infant can be biologically adapted so multiple parents can experience that physiological bonding.
The underlying science of lactation, the manipulation of prolactin and oxytocin, can be pharmacologically and mechanically stimulated even without a preceding pregnancy.
That's incredible.
It is a prime example of modern medicine meeting families where they are to facilitate those crucial early attachments safely.
But no matter the family structure, the physical roadblocks are intense. The text breaks down engorgement when the breast becomes so pathologically swollen with milk and interstitial fluid that the milk flow is literally blocked.
Very painful.
And mastitis, an inflammation and infection of the breast tissue causing severe flu-like symptoms.
So what does this all mean? Wait, because when I look at the treatments for engorgement in this highly clinical medical textbook, it ranges from anti-inflammatory drugs to raw cabbage leaves in the bra.
Oh, yes. The cabbage leaf.
Wait, is this real science or an old wives' tale that somehow made it into the textbook? Well, the authors explicitly state there is a lack of evidence to support its effectiveness.
So no hard science on cabbage magic.
Exactly. We do not have large-scale, double-blind, randomized controlled trials proving that a specific sulfur compound in cabbage miraculously cures engorgement.
Then why include it in the medical guide alongside ibuprofen and reverse pressure softening?
Because clinical medicine often has to bridge the gap between hard biochemical pathways and practical community-derived realities.
Okay. Wow.
Engorgement is intensely painful, and cabbage leaves are naturally cool, shaped perfectly to cup the breast tissue, and incredibly inexpensive.
They do fit the shape pretty well.
Right. Patients consistently report subjective relief. It is a low-risk, high-comfort intervention that does no harm. It demonstrates that symptom management in the real world sometimes leans on practical traditions, while the hard science focuses on resolving the underlying fluid blockages.
Comfort allows the body to relax, which probably helps trigger that oxytocin letdown anyway. But what happens when the real-world roadblocks? Whether it's a need for maternal medications, previous glandular surgeries, or just personal choice. Direct breastfeeding isn't going to happen.
It happened all the time.
How does science step in to meet that incredibly strict macronutrient blueprint we discussed at the start?
When a mother's own milk isn't available, the highest recommended alternative, particularly for vulnerable or premature infants, is pasteurized human donor milk.
Okay.
The text highlights HMBAA, the Human Milk Banking Association of North America. They are a rigorously regulated network that screens donors similar to a blood bank.
And they pasteurize it.
Yes, they carefully pasteurize the milk to destroy pathogens while preserving the structural integrity of the proteins and antibodies.
But the FDA also issues a massive, bold print warning against informal internet milk sharing. People are trading breast milk in online groups.
Yes, they are.
Buying breast milk on the internet sounds like buying a used car without a Carfax. You have absolutely no idea what's under the hood or where it's been.
The risks are profound. Without laboratory screening, informal milk sharing can expose a medically fragile infant to cytomegalovirus, HIV, pathogenic bacteria from improper breast pump sterilization, or even pharmaceutical drugs the donor didn't disclose. The pasteurization and screening steps are non-negotiable for safety.
This raises an important question. The text mentions a bioethical dilemma regarding the milk banks themselves. If donor milk is so valuable, what is the conflict?
The tension lies between nonprofit and for-profit banking models. HMBNA operates strictly as a nonprofit, dispensing milk entirely based on medical triage.
Meaning the sickest babies get it first.
Exactly. The sickest neonatal intensive care infants get priority. However, for-profit companies have emerged that pay women for their milk, process it and sell it to hospitals or private consumers.
I see the problem.
The bioethical concern documented in the text is that financial incentives might lead low-income women to sell their milk rather than feed it to their own infants,
Wow.
which potentially diverts a highly valuable clinical resource away from the equitable, needs-based nonprofit system.
That is a complex systemic issue, which brings us to the importance of commercial formula as a safe, vital alternative.
Absolutely vital.
The text emphasizes that commercial formulas are highly regulated, but human error in preparation is where the danger lies. You can never use unmodified cow's milk or goat's milk, and you absolutely cannot over-dilute the formula to stretch the can further.
Over-diluting brings us right back to the beginning of our conversation. Hyponatremia.
The plain water problem again.
Exactly. Too much free water and not enough electrolytes will cause brain swelling and seizures. The preparation ratios are mathematically exact for a reason.
And the text even approaches bottle feeding mechanically, advocating for paced bottle feeding. You hold the bottle horizontally, not vertically,
Right.
so the baby has to actively draw the milk out, rather than gravity just pouring a continuous stream down their throat.
Gravity feeding forces a baby to gulp rapidly, which can lead to swallowing air and triggering vagal nerve stress.
Nobody wants a stressed baby.
No. Holding the bottle horizontally allows the infant to control the flow. They can coordinate their suck, swallow, and breathe reflex without choking. It mimics the natural pauses of breastfeeding and prevents dangerous overfeeding.
It really emphasizes that whether a family uses breast milk, donor milk, or formula, the absolute goal is respecting the physiological boundaries of the infant.
Always.
We've covered incredible ground today. We started at the micro level, exploring how a 60-40 weight-to-casein ratio dictates gastric emptying.
We did.
We mapped the hormonal factory of prolactin and oxytocin, navigated the cultural nuances of las dos cosas, and unpacked the rigorous science of formula and donor milk safety.
That's a lot to take in.
It is. So, to you listening, whether you are prepping a bottle right now, supporting a nursing partner, or just marveling at human biology, you now have the factual bedrock of how human life is sustained in its first 6 months.
And as we close, I'm going to leave you with a final thought to mull over.
Let's hear it.
We've learned today that human milk is a dynamic, living tissue that literally alters its own cellular composition based on the real-time pathogenic exposure and developmental stage of the baby.
Yeah.
If the human body can manufacture such a perfectly tailored, real-time immune-boosting therapeutic for infants, what does this mean for the future of adult medicine?
Oh, wow.
Right. Could scientists eventually learn to engineer dynamic, living nutritional therapeutics that adapt to our own adult immune systems in real time, exactly the way breast milk does for a newborn?
That's wild to think about.
Yeah.
If we can ever decode that biological software, the future of medicine might just look a lot like our very first meal. Thanks for joining us on this deep dive. We'll catch you next time.